All right, guys, it's Dr. Marquez here. We are going to be doing a quick recap of some significant areas that I think will be important for you to ensure you have familiarity with, as well as a basic understanding regarding some important concepts regarding psychoanalysis, mental health, overall psychotropic perspectives of medication management, and different diagnoses that are commonly and often seen in mental health. So first chapter I want you guys to take a look at incorporates the biological basis for understanding psychiatric disorders and treatments. I'm going to kind of skip ahead and go to areas that are important. You will be expected to know the actions of neurons, particularly understanding the perspectives of how neuronal activity occurs, looking at the synaptic changes that occur regarding messages being sent, and altering particular areas of functioning as it relates to disturbances or dysregulation in certain neurotransmitter. The neurotransmitters that we're going to look at specifically are going to be norepinephrine, serotonin, dopamine, glutamate, and GABA. One that isn't mentioned here, but is also important for you to know, is acetylcholine, because it does have a significant effect on a mental health disorder that, again, is a little bit controversial to have under mental health, but acetylcholine and the dysregulation of acetylcholine has a lot to do with things like dementia and organic brain syndrome. So that one isn't mentioned here, but that is also an important neuron that you need to be aware of as far as this mechanism of action. The big one here, all of them are important because they have certain aspects that affect a individual's mental health, but serotonin is often related to quite a few disturbances, and we'll talk about that as we move forward. But you do need to know norepinephrine, serotonin, which is also known, norepinephrine, which is also known as the fight or flight response. You'll see it often discussed as when we look at the other aspects of norepinephrine, you'll see that there are medications like serotonin, norepinephrine reuptake inhibitors that are often interchangeable because utilized with serotonin, norepinephrine, and serotonin have a lot to do with things like stress and anxiety. So you're going to see norepinephrine also interchangeably used with endorphins as well. Okay. All right. We're going to talk about medications, just do a quick recap of medications. So your benzodiazepines, the PAM sisters, are often what we acclimate or what we associate with the PAMs. Valium, Klonopin, Xanax, and Ativan. Diazepam, clonazepam, alprazolam, and lorazepam are all benzos. It is important to remember that they are to be utilized on a short-term basis. Unfortunately, people do use them on a longer-term basis than what's recommended. When you look at some of these medications, do be conscientious that they are highly addictive. People can become dependent on them, and you can also start to become tolerant to the medications as well. Medications used from a injectable perspective that you're going to see for patients that have panic disorders or severe anxiety, in particular in the hospital. If you have a patient show with a panic attack, they're often going to be given Ativan, because Ativan can be given IV or IM. The rest, Xanax, clonazepam, and diazepam, are PO as well. So the lorazepam is usually your medication given in the hospital, and it's usually given IV for panic disorders. Again, there's a variety of benzos that can be prescribed. All of them are considered controlled substances, so it is important to educate patients about not taking these medications with other medications or other substances that can cause respiratory depression, particularly alcohol or other illicit substances. These are some other hypnotic drugs: flurazepam, temazepam, trazodone, escitalopram, and clozapam. and don't use that one too much. Temazepam is often used in the hospital. It's also known as Restorol to help patients sleep when they're in a foreign environment. So Restorol is often used for sleep-wake disorders or insomnia as a result of environmental stimuli. Again, all of these are highly addictive, so it is important that you educate the patients about not taking these with other substances such as alcohol or drugs, and maintaining short-term use of it. These are your hypnotic drugs, or what we call the Z hypnotics. They would be zolpidem, Zolpidem, and aceclidine, which is Lunesta. So it's Ambien, Sonata, and Lunesta. All of these medications are prescribed for sleep-wake disorders, particularly insomnia. Again, patients can become dependent and they can become addicted to the medication. So you want to use it cautiously and educate the patient about taking it sparingly, not taking it every night. Really, it is used for severe insomnia. So some of your melatonin receptor agonists, Rosaram, Celeneram, Buspar. I've talked about buspirone before. Buspirone is actually a really good medication to utilize for chronic anxiety, agitation, and irritability. It is non-addictive in nature. So the anxiety medications, if you're going to prescribe something for more of a chronic issue associated with those symptoms, buspirone would be a more appropriate medication to prescribe. Your antidepressant drugs, your TCAs or tricyclic antidepressants like amitriptyline, nortriptyline, and imipramine, or Pamellar, Elavil, and Tofranil. All of these medications can and have been used in the past for treatment of depression and anxiety. We don't use them quite as much as we used to, just because the tendency with side effects of these medications is much higher. So we try to utilize medications that don't have as much of a tendency to have side effects. Number one side effect with using TCAs is going to be actually all psychotropic medications, number one side effect is gastrointestinal irritability. Constipation, nausea, reflux. Patients will complain about cramping as well. TCAs also can have a significant sexual side effect too. Amitriptyline can help with sleep-wake disorders as well, so we do use it at night too, as well as amitriptyline and imipramine can also actually help with migraine disorder or severe headaches, or as prophylaxis for headaches. Okay. Your SSRIs are going to be your number one go-to medication regarding an antidepressant utilized for depression and anxiety. These medications are most often prescribed because of the side effects being much less with the use of an SSRI. So this is your go-to medication. Fluoxetine, sertraline, paroxetine, citalopram, escitalopram, and fluvoxamine. These are all medications that would be more appropriate to use initially versus jumping to a TCA. We usually will try a couple different SSRIs before we put a patient on the TCA, just because we're concerned about the potential for side effects. So always go to an SSRI before you try a different type of antidepressant. SNRIs like venlafaxine, desvenlafaxine, and duloxetine, they can be utilized as well because they are a serotonin norepinephrine reuptake inhibitor. The big one with this one is that they have a lot of dual combinations as far as what their directive is for, meaning what we use them for specifically. Duloxetine, like Cymbalta, is used a lot in pain management because it also works on the GABA receptors as well. So it can help with pain control. It's not pain medication, but it can help alleviate some experiences with pain. So if patients have depression or anxiety, but also have accompanying physical pain, we can prescribe duloxetine. Venlafaxine, good medication, does have a tendency to cause significant weight gain. A lot of patients who have used it before say it works great, but they have a tendency to gain weight on the medication as well. Pristiq, good medication too, has a little bit longer acting effect with it, but it's a significant potential for sexual side effects with SNRIs. The serotonin norepinephrine disinhibitor is mirtazapine or Remeron. Mirtazapine is used for patients that have significant sleep-wake disorders or insomnia. So it's utilized for patients that have a dual modality with depression and insomnia. Patients take it at night. It has a significant side effect of making the patient drowsy or sleepy. So it is taken in the evening to help with sleep-wake disorder as well. MAOIs like azacopoxide, phenylazine, selegnine, and trimethylclopramine, parnate, and some Nardil and Marplan, all of these medications, of all the medications regarding prescribing in order of what has the least amount of side effects, MAOIs would probably go third in line of utilization because it can have some significant GI side effects with it. There's also certain foods that are contraindicated to utilize with MAOIs. So you want to stay away from your pteramine derived foods. So that would be like your aged cheeses, red wine, grapefruit. So it does have certain types of cured meats as well. So that it does have some contraindications of certain foods. Just some of your other antidepressants, bupropion, Wellbutrin, or Zyban is used oftentimes for patients who also have a smoking disorder. So patients who are desiring to cease their smoking habit, bupropion is used well with that. You can pair bupropion as well with SSRIs. You have a fairly significant cohabitation positive effect for the patient. So you're going to see a lot of these medications co-utilized with other types of SSRIs. Trazodone is helpful for insomnia too. Mood stabilizers are used for patients with bipolar disorder or mood disorder. First medication you see is lithium. Lithium is the go-to medication for patients that have bipolar disorder. It is the most significant lasting effect regarding addressing patients with bipolar disorder. So it is usually the go-to medication. You do need to know the therapeutic range for lithium, 0.5 to 1.2. There's a couple of, like the book has a little bit of a different level associated with some of the other literature out there. And the significant component to look at with lithium is that anything over 1.5 can be toxic in nature. So it's got a very short therapeutic index. Some other drugs that we use for mood stabilization are going to be like your Depakote, carbamazepine, lamotrigine, gabapentin, topiramate, and oxycarbazepine. Again, these are usually your go-to drugs if lithium, the patient isn't compliant to utilization of lithium, like having their blood draws checked periodically to ensure that the patient doesn't become toxic on the medication. We usually want to do a baseline lithium level on the patient and then check them again in 6 weeks, 3 months, and then thereafter every 3 months for the first year. And unless the patient is having any kind of significant side effects associated with utilization of lithium, you can usually do maintenance every 3 to 6 months thereafter, as long as there aren't any changes into the dosage. Your antipsychotic drugs are classified as FGAs or first generation antipsychotics. They are the conventional, typical standard antipsychotic drug that bind to the D2 receptors. They block attachment of dopamine, and they reduce the dopaminergic transmission. So we use these for patients that have schizophrenia, some SMIs or serious mental illnesses, but the antipsychotic drugs are fairly significant in not just their utilization as far as compliance is concerned, for them to be as effective as possible, but their side effects can be significant. And this is a lot of the reason why we can't get patients to stay on them. They're antagonists of receptors for acetylcholine, norepinephrine, and histamines, but the significant side effects are associated with weight gain and sedation. When I say weight gain, I talk about significant weight gain, 30 pounds or more. So it can be really disheartening for the patient if they already have low self-esteem to then gain significant amount of weight. Your SGAs, or your atypical antipsychotic drugs, produce fewer extrapyramidal side effects. They target both negative and positive symptoms. You do need to know negative and positive symptoms. Remember what I told you guys. Memorize what your negative symptoms are. And if you do that, then everything else would be, all your positive symptoms would be fairly easy to remember, just because there's not as many symptoms associated. They're often chosen as first-line treatment because of the lack of side effects associated. And then you've got, when we look at SGAs, we look at dopamine and serotonin blockers associated with those. These are samples of SGAs, second generations. Most often you're going to see risperidone and quetiapine used. Olanzapine is a good drug, and so is the but those are the ones that you talk about, the significant side effect with weight gain. Also polydipsia, dry mouth, patients that will complain of feeling really sedated and sleepy on these medications. Paliperidone is a good medication. It can be used on a long-term basis because it can be prescribed as an injectable as well. So it lasts a patient like a month while they're on it. And it does have to be administered by a nurse, and it has to be administered in the office so we can actually watch the patient afterwards for any type of side effects. And lastly, your aripiprazole or Abilify, which is a dopamine stabilizer. It's probably most effective of all the medications, but it's also extremely costly, very expensive, and you have to basically prove to most insurance companies that you've tried everything else before they'll approve you to go on aripiprazole or Abilify. Other drugs, we use medications for ADHD. ADHD is a disorder that's usually associated with childhood onset or adolescent onset, but it can manifest into adulthood as well. Medications we use for that are going to be stimulants. Stimulants, like some of your other controlled substances, have to be watched very carefully. Unfortunately, the use of these medications on the streets when cut with junk from the streets can and then cooked can result in meth on the street. So we want to be very conscientious of how it's prescribed. There is high misutilization of stimulants prescribed for ADHD. Methylphenidate, dextroamphetamines, atomoxetine, Intuitive, and Capve are some of the samples of this medication. For Alzheimer's disease, you're looking at medications that help with dysregulation of acetylcholine. For Alzheimer's, you're going to look at tacrine, donepezil, which is most often the medication that's prescribed, galantamine, rivestamine, and memantine. Memantine is also used. Do understand all these medications are used hopefully to slow the progression of the disease. But they are not cures by any means. The goal is just to help with the progression of organic brain syndromes. Some herbal medications we want to be conscientious of are medications they can get over the counter, such as St. John's wort, which has an anticoagulation effect. Long-term effects of herbal medications, depending on what they are, you can see nerve damage, kidney damage, or liver damage. It just depends on what the patient is taking over the counter and what type of mix they're putting together. And there are possibilities of other adverse chemical reactions. One of the big ones that we look at right now is the utilization of THC or cannabis. And it really, if you put a patient in antidepressant and then they're using THC or cannabis for assistance with their anxiety, you're basically countering the effect of an antidepressant when you're utilizing THC, which is a depressant. So it may potentially help with anxiety, but it's not going to do much for your depression. Okay. A person has a decrease in circulating. You guys can go ahead and read that. I just wanted to kind of go with those components with you guys. Okay, I'm going to pause for a second. We'll get to the next piece. So give me a sec. All right, so let's take a look at legal and ethical guidelines for safe practice. I'm going to skip ahead, kind of give you some components of legal areas that you need to be aware of. the different types of admission procedures associated with admissions into a formal setting, specifically looking at hospital admission. So an informal admission is when the patient themselves seeks to be admitted because of either a threat to self or threat to others, suicidal or homicidal ideation. A voluntary admission is when it's sought by the patient or guardian. A temporary admission is when the person is confused or demented, or they're so ill that he or she needs emergency admission. Remember, there are 3 reasons to admit a patient to the hospital for a psychiatric disorder, and that's going to be threat to self, threat to others, or gravely disabled. Gravely disabled can be a patient who has advanced dementia or is unable to do basic care for themselves, eating, sleeping, bathing, because they're so cognitively impaired that they cannot do these functions independently. We don't usually keep patients that are demented unless they're legitimately trying to hurt themselves or hurt somebody else. But the goal is to really try and place them so that they can be in a safe environment, because it's more their inability to function independently. So usually those patients we try to transfer out of a acute care hospital that deals with psychiatric emergencies and find them something a little bit more stable. And involuntary admissions is without a patient's consent. And again, this can be as a means of assessment that's been done, and involuntary admission is indicated for that patient. Long-term involuntary admission needs medical certification, judicial review, and administrative action. So you can't just put a patient into the hospital and say you're going to be here for 30 days. We know that there are certain WIC guidelines that we'll look at right now in order for a patient to be admitted and what types of admission it's deemed. Involuntary outpatient admission is also a perspective to look at. Discharge procedures, you can have a conditional, unconditional, or an AMA discharge. Conditional release is often used for patients that have alcohol abuse disorder or some type of drug addiction, and they're mandated after release from the hospital to attend like a 12-step meeting, or they have to go to so many AA meetings, or they're going to be released to a family member or a guardian. So they're not released without any, or they're released with restrictions. Unconditional release is basically no restrictions. The patient is independent to be able to release to be home. And a release against medical advice, where the patient may not have been deemed to be threat to self or threat to others, but maybe they have. It is indicated that they should be in another facility or they should go with family. We can still release them, but against medical advice would mean that they're going against what is being advised for them. Patients' rights under the law, right to treatment, right to refuse treatment, and right to informed consent. It is considered battery if you do something to a patient and do not give you consent. So it does not mean if a patient is in a mental health facility that they don't get the same rights as any other citizen or any other patient. Okay, they have the right to involuntary commitment, surrounding involuntary commitment and psychiatric advance directives, rights regarding restraint and seclusion, rights to commit confidentiality. What they don't have a right to is a private room. Be nice if everybody could get one, but that is not a right. HIPAA, confidentiality after death, confidentiality of professional communication, and so forth is also intact for the patient. There are a few exceptions to the rule. We talked about the duty to warn as providers if the patient has deemed to you that they're going to hurt someone or they have a plan or intent to cause harm to another person, as well as child and elder abuse. I don't need to know too much about tort law. Okay, let's go to the next thing. All right, guys, so let's go ahead and take a look at the WIC document I want you to be aware of. Okay, everybody needs to know these. All right, these are your welfare and institution codes utilized for admission purposes and to understand what type of admission the patient is going to be admitted into, or what the rationale would be. So if you look at a WIC 5150, most of you should be aware of this. This is also known as a 72-hour hold. It is defined as detention of mentally disordered person for evaluation and treatment for a period of 72 hours for persons alleged to meet the legal criteria of being a danger to self or others or gravely disabled due to a mental health disorder. Okay, if the patient is admitted, and we deem that the patient has to be overseen a minimum of 72 hours, as a hold will be maintained. If the patient is deemed to need to go beyond the 72 hours, then we're going to look potentially at a WIC 5250, which is certification for intensive treatment for a period of 14 days for persons alleged to meet the legal criteria of being a danger to self or others or gravely disabled due to a mental health disorder. A WIC 5260 is additional intensive treatment for a suicidal person. So we've already deemed the patient has a suicidal tendencies or intention. Certifications for an additional period of 14 days beyond a 5250, the first 14 days, to persons who are allegedly imminently suicidal due to a mental health disorder. A WIC 5270.15 is also known as a 30-day hold, and this is additional treatment, intensive treatment, for an additional period of 30 days beyond the WIC 5250. So you see that we went from a 5250, which is 14 days, to additional 30 days. So you can go from a 5250 to a 5270-15 for persons who are gravely disabled and so forth. And then your WIC 5300 is known as 180-day post-cert, which is the procedure for imminently dangerous persons for a period of 180 days beyond a WIC 5250, which is your initial 14-day hold for persons who allegedly made a serious threat or substantial physical harm or attempted or inflicted physical harm on another due to a mental disorder. So do know these. They are important for you to be aware of because you do need to know the legal statutes associated with these types of admissions as well. Okay. Okay, on this slide, I have one particular slide I really need you guys all to know, and that is your mechanisms of action associated with your neurotransmitter and the neurotransmitter function. So let me take a look at, I want to say, I believe it is, oh, there it is. Slide number 7 on the neurotransmitter slides. Know this chart. You have to know it. These are your neurotransmitters and their function. So if I ask you specifically, memantine is utilized for patients with Alzheimer's disorder. What neurotransmitter is most associated, or the dysregulation of what neurotransmitter is associated with Alzheimer's disorder? You would need to know acetylcholine and glutamate. Those are your two most dominant neurotransmitters associated with that disorder. I may say a patient has a history of alcohol abuse disorder or of ingestion of illicit substances or some type of compulsive disorder associated with drugs or alcohol. You'll need to know that the two that you're looking at specifically would be dopamine, dysregulation of dopamine, as well as norepinephrine. For the most part, when we look at that type of thing, we'd want to see that, issues associated with pleasure and reward feelings or dysregulation associated with dopamine has a lot to do with those types of disorders. And then the pleasurable feelings that come with them as well. So it would be both of the neurotransmitters involved and which one is most predominantly involved. So this is what I want you guys to memorize. This slide number 7 is super important. So please, please know this one. I guarantee you're going to get questions about this slide. Okay. So do make sure you go over that. And you're going to have more than one neurotransmitter associated with most of your disorders. For instance, stress, anxiety, depression are going to involve serotonin and endorphins or norepinephrine. To some extent, you may also see some issues associated with if a patient has like aggressive, angry, or has irritability associated with their anxiety. You may also see some GABA mixed in there. I'm not going to get as specific as that if I'm going to use that type of a scenario, but you do need to know what neurotransmitters would be dysregulated when you look at these types of issues. Okay. All right. So now that one. Okay, this is chapter 8. I skipped ahead to therapeutic relationships. Chapter 8 really focuses on the establishment of the therapeutic relationship with the patient. The important thing to remember about therapeutic relationships in mental health is that, honestly, this is very one-sided. This is not about us as the nurse, it's about the patient. And whereas in a regular or normal relationship, it's reciprocal in nature. You ask a question, someone responds, they ask you a question similar to what you have asked, so that you have that opportunity to really delve into both sides of a conversation. And this is not to say that your responses to patients need to be monosyllabic or cold in nature, but the establishment of therapeutic relationship really depends on you allowing yourself to be there for the patient and making them the focus of the relationship. The needs of the patient are identified and explored. It doesn't say needs of the patient and nurse are identified, explored. This is about the patient. Clear boundaries are established. This is not a friendship. This is not a relationship that's going to lead to you having coffee or dinner one night. It's about you being there for the patient from a professional perspective and offering self. You want to take a problem solving approach to this, develop coping skills, and help the patient develop their coping skills and change the behaviors. You can never make a patient change who they are, but you can help them identify behaviors that are affecting them negatively. Some of the areas I want you to ensure is that you understand the blurring of boundaries can occur. And the reason is that information is shared that is very personal in nature. And when a patient's sharing that type of information, they start to create a bond with you. But when this relationship slips into a social context, or when the nurse needs are met at the expense of the patient's needs, then these boundaries have been blurred. When we look at the concept of blurring of roles, one of the main components to look at are two issues that need to be addressed, and that's the issue of transference. This is when a patient unconsciously and inappropriately displaces onto the nurse feelings of the behaviors related to significant figures in the patient's past. Transference intensified in relationships of authority. So the patient looks at you and then you remind them of a friend or a wife or a husband or a significant other. And because of that component of them looking to you as someone they relate to also gives you more authority in the relationship. So you have to be careful with that, because it can lead to some significant negative outcomes. Countertransference on the other side is really when it's the nurse that displaces feelings related to people and the nurses pass onto the patient. So this is the nurse projecting onto the patient. Patient's transference to the nurse often results in countertransference. So it's this blurring between both the patient and the nurse. And common signs of countertransference in the nurse is over identification with the patient, saying things, oh, like, I know how you feel, or I've been through that experience before, or I have a brother who has experienced the same thing. Again, remembering this is not about us, this is about the patient. So no transference and countertransference, because those are two main topics that you need to be conscientious of. Okay. Okay, this is chapter 10. This looks at the stress response. Some of the theoretical ideas behind stress response have to do with concepts developed by Dr. Walter Cannon. He looked at the fight or flight response, the run to it or run away from it response. This is really the body's perception of protecting itself. It prepares for a situation that an individual perceives as a threat to their survival. New research indicates that men and women have different neuronal responses to stress. We know that neuronally, we're going to be looking at serotonin and norepinephrine as two of the major neurotransmitters associated with stress. Soleil looked at the JAS, or the general adaptation syndrome. We've got 3 stages to stress, which are the alarm or the acute stress stage, resistance or adaptation, and then exhaustion stage. Psychological reactions were developed by Lazarus, and these are 2 concepts you need to know: distress and eustress. Eustress is positive. It means that it's protective in nature. It means that if you were to go to a corner and there was a lot of traffic, and your eustress is protective in nature because it's stressing you to the perspective that you don't want to put yourself in danger by putting yourself out in traffic. So it protects you from doing things that potentially are dangerous to yourself or could cause harm to yourself. So eustress is not a bad thing. Distress can be a negative component of a mental health reaction if it causes you to not be able to function, if the distress becomes so life altering that you can't get out of bed, you can't get up to brush your teeth, you're so stressed about your environment around you that you're unable to engage in your regular activities. So that would be considered a negative response. We know that neuronal stress transmission involves serotonin synthesis becoming more active. So we see more active dysregulation in the neuronal transmission of serotonin. This can impair receptor sites and brain's ability to use serotonin. Let's see, anything else? It can be physical and psychological in nature, meaning stress can have a physical manifestation on your body. Sometimes we call it a somatic issue, like when you're having mental health issues and you have physical response to a mental health issue. Extreme stress or severe stress can cause the patient to become panicked as well. That concept between interrelatability of stress and anxiety are very close in relation. Depending on how bad it gets, you can have a physical response to it as well. Some of the things to help with manage stress through relaxation techniques are like deep breathing, progressive muscle relaxation, relaxation response, meditation, guided imagery, things that you can do environmentally. Exercise is really, really good for stress. It just creates natural endorphins in the body as well. Okay. Okay, that's it. All right, let's look at schizophrenia and schizophrenia spectrum disorders. It really doesn't have any, it's important to remember that it doesn't have any specific rationale associated with race, social status, or culture. It can affect anybody, and it does not differentiate between race, culture, social status, or culture. So it crosses the spectrum. Some of the comorbidities are substance abuse disorders, anxiety, depression, suicide, physical health or illness, issues with polydipsia, being thirsty a lot as well. There are patients that are genetically predisposed to schizophrenia if there is a history in the family. Neurobiologically, the dopamine theory looks at how the transmission or the dysregulation of transmission of dopamine can be associated with positive symptoms of schizophrenia. So not necessarily positive and negative, but it's a really factor that's associated with positive symptoms. So the theory is that you're going to see the dysregulation of dopamine as a result. From a neurobiological perspective, the 3 neurotransmitters associated with schizophrenia are going to be dopamine, glutamate, and serotonin. So dysregulation of all 3 of those neurotransmitters are linked to schizophrenia. And that would be your other neurochemical hypotheses. Some of the psychological environmental factors, some of these, we look at the data associated with them, and following these from a long-term perspective is a little bit harder with prenatal stressors wise, but psychological environmental stressors are indicated to exacerbating the disorder. We're going to look at the phases of schizophrenia, the acute phase, which is when it initially occurs. We're going to often see this in early and late teens, 18 to 21. And the thought process is, a lot of times they can learn how to compensate when they're home. They learn how to deal with the issue. They learn to work around it. They're in a familiar environment. And then when you send them off to college or you send them off after high school on their own or whatever the case may be, they're no longer in this situation or in this environment that they're comfortable or they can manipulate because they learn how to do it. So the first acute onset often happens between the ages of 18 and 21. So when the person arrives to college or is out on their own. Phase 2 has to do with stabilization. This is when the symptoms begin to diminish. The movement toward previous level of functioning is started. So this is when the patient's on medications, the patient's seeing a therapist, the patient is more stabilized because they've been on a routine that addresses their plan of care more appropriately. And then maintenance is really looking at or near baseline functioning. So what they were previous to their mental breakdown or the issues associated with the acute exacerbation. Let's take a look at the positive symptoms and the negative. So here's all your positive symptoms: delusions, which are false fixed beliefs, ideas; concrete thinking, inability to think abstractly; alterations in speech, associated looselessness, like clang associations, word salad, neologisms, echolalia. These are all of your positive symptoms. So here's what I tell you to do: memorize your negative symptoms because they all have to do with affect. And this would be like a flat affect, blunted, inappropriate, even bizarre. If you memorize your negative symptoms, everything else is pretty much going to be positive. And that can range from everything from catatonia to motor retardation to motor agitation. So know your negative symptoms for sure, because then everything else is pretty much going to be positive symptoms. I know it sort of has like a strange connotation because you would think it would be good to hear positive. It just means that you're having these particular symptoms. So do be conscientious of that. You got to check for potential depression because there's a high rate of comorbidity with it. Patient with schizophrenia says there are worms under my skin, eating the hair follicles. How would you classify these symptoms? If we go back to our positive symptoms, it's actually hallucination, auditory, command, visual, thought insertion, thought deletion, flight of ideas. See if they have anything. Let's see, I'm trying to see. Trying to see if there's something specific. Well, it would be delusional in nature. Do remember the hallmark of schizophrenia is hallucinations and being delusional as well. There are 3 types of hallucinations: auditory, command, visual. There's others as well: tactile, olfactory, but these are the ones that you're going to see most often associated with schizophrenia. Tactile hallucinations are usually associated with patients that have you can see them with schizophrenia, but they're not as predominant as they are with patients that have some type of drug abuse disorder. So auditory, about 80% of the time, a patient who has schizophrenia is going to have auditory types of hallucinations. The next would be command and visual. The one thing, if the patient tells you that they're seeing things or they're hearing things, the important thing to ask is, are those things telling you to do something? Are they telling you to hurt yourself or hurt other people? Those would be considered command because the hallucinations are actually telling them to do something. Okay, so those are some important aspects to remember. Memorize your negatives. Everything else is pretty much going to be positive. Okay. So let's look at ADHD. Again, we talked about it a little bit in the beginning. ADHD is usually recognized in elementary school, sometimes in middle school, but for the most part, you'll start to see issues associated with attention, concentration, inattention, focus, memory, all of those types of symptoms associated with ADHD. Usually in grammar school around the age of 7. It usually appears in early childhood, but it can appear a little bit later, especially if the kid has not had it diagnosed. Signs and symptoms of ADHD typically occur about the age of 7. It can be difficult to distinguish between ADHD and normal kid behavior. Is this just, a child that's very excitable and, someone, the class clown, just wants attention versus someone who really can't focus or concentrate or has difficulty in completing tasks? There are it's known in various cultures. Western countries probably have more association with it because we test for it more often. So about a 7% average in children as far as seeing this disorder occur, anywhere from 3 to 7%. The subtypes of ADHD are classified by the 6x6x6 rules, which are ADHD combined type, which is the most common type of ADHD seen. It's usually when there's 6 or more symptoms of inattention and 6 or more symptoms of hyperactivity / impulsivity have persisted for at least 6 months. So again, the 6x6x6 rule, most children and adolescents with this disorder have combined type. This is ADHD, predominantly inattentive type, basically the same thing, except that you have fewer than 6 symptoms of the hyperactivity and impulsivity occur. However, in attention, you have 6 or more symptoms of inattention that occur. And again, this has to be 6 months. Same thing with the predominantly hyperactive type. You're going to see less symptoms of inattention, but more so with symptoms of hyperactivity and impulsivity. So you want to identify the 6x6x6 rule. And again, we put it for 6 months specifically to see, from a range perspective, how long has this child been having issues with this. We don't want to do it from an acute basis. Maybe the kid's very excitable at some point. Maybe they like somebody in their class. Maybe they just want the attention, but it's not transient in nature. This type of behavior really needs to be maladaptive and inconsistent with developmental level. If you've got an 8-year-old who's used to sitting in there, you've got a classroom of kids and 28-year-olds are sitting there at their desk coloring, and every day you have to fight with a child because they're never in their desk, they're never doing what they're supposed to be doing. They're taking their shoes off, they're running around the classroom, they're playing with audiovisual equipment. So it's inconsistent with their developmental level. Here are your diagnostic criteria with inattention. So if you're doing the 6x6x6 rule and it's predominant inattention, then you'd have to have 6 of these diagnostic criteria, and less so with the hyperactivity, impulsivity, and vice versa as well. Do know the different factors associated with those. It can be difficult to distinguish between symptoms of ADHD from age-appropriate behaviors in active children. Kids like to run around and be noisy versus kids who really are having a really significant issue in functioning at school. We use medication-wise. We do use, we're going to use stimulant. Well, I did want to mention the 2 neurotransmitters associated with dysregulation with this disorder are going to be dopamine and norepinephrine. Remember, we were talking about memory, inattention, focus. So all those things are challenged in this particular disorder. So again, all right. Remember, dopamine and norepinephrine are your 2 neurotransmitters associated with this disorder. Okay, so let's talk about autism. Autism is characterized by a umbrella term associated with the term pervasive developmental disorder. There's a few different disorders that fall under this generalized term, but autism itself is categorized as a PDD. It is characterized by difficulties in social interaction, verbal and nonverbal communication, repetition in behaviors, intellectual disabilities, and difficulties with motor coordination and attention. Some of the aspects regarding demographics wise, about 1 in 110 American children have autism. This is about a 600% increase over the past 2 decades. There's not a lot of substantiation as to why, other than we do know that there is some impact associated with mothers who have babies over the age of 35. So advanced maternal age has been linked. There is no linkage between vaccinations. For a while, there was a rumor that was really being mongered by celebrities and unfortunately gained some traction, but autism is not caused by vaccinations, in particular MMR. MMR was the vaccination that was pointed out as potentially having a link between symptoms of autism. This has been debunked. There is no research to substantiate that claim. So if you get asked a question about it, it is not true. It is not there is no evidence to support that claim. Signs and symptoms, impairment in social interactions, impairment in communication, and again, looking at restricted repetition and stereotype patterns of behavior, the rocking back and forth, the pill rolling, the repetition of sounds, the echolalia. So all of these types of symptoms can accompany autism. Autism is put on a spectrum as well. It can be fairly pervasive, have some significant issues associated with symptomology. And then on the spectrum, it can be not as pervasive as well. There are a lot of functional people that have autism for a significant amount of time. It was also coined Asperger's syndrome. We don't use that anymore. We just say that the patient is on the spectrum because there's a wide variation between how pervasive the disorder can be. So you can function on autism, and it can go all the way to being highly non-functional as well, depending on how many symptoms are present and how pervasive the issue is. Some of the biological signs in large portions of the autistic brain are often seen. Abnormal genes can be identified, including ones that may alter brain architecture. Genes can interact with environmental factors, and the major brain areas implicated in autism are the cerebellum, cerebral cortex, temporal lobe, and the amygdala. Neurobiology perspectives, it's commonly believed to be caused by widespread abnormalities in brain structure and function that occur prenatally and in early life. Neurodevelopmental trajectory is altered by cell migration, formation of neuronal networks, neurotransmitter systems failing to perform optimally, and communication between neurons may be impaired. There's not one that's specifically, you can look at, movement disorder, you can look at stereotypical behavior, so associated with dopamine, but then you also have issues associated with mood. This is more neurobiologically associated with formation of or misformation of neural networks as a result of widespread abnormalities in brain structure. So it's more anatomically based as well from a functional perspective. Can be related to excess brain overgrowth during the first 2 years, and then regionally specific areas of the brain start to become affected. We usually don't see symptoms occur until about second or third year of life, when higher level functioning like language, complex social interaction that requires integrational complexity to emerge. So usually we're not going to see a lot of the symptoms associated with autism until like the second or third year of life, when more, like I said, high level functioning occurs. This again is because it affects so many components of the brain, it is considered a whole brain integration deficit. So versus neurologically affecting the neurotransmitters, because it has so much more to do with the brain, the function of the brain as it relates to components of the brain not being having pervasive issues with development or overdevelopment or underdevelopment. It's again more anatomical in nature and neurobiological in nature. If we look at the amygdala, larger amygdala in autistic children and adolescents, adults, the amygdala appears to be the same size or smaller. Larger amygdala means increased anxiety, poor social skills and communication, processing, distinguishing faces, understanding sensory stimuli and social stimuli. There really are no specific tests for autism. It is identified in the DSM criteria. It's more of a rule out type of diagnosis. So they do various testing to see what issues may be present in this child. Again, there's no cure for autism. Early intervention is important. Things like OT, PT, sensory integration therapy, some of the health considerations. These children do have a tendency to have GI issues, leaky gut, food allergies. It is often suggested to put a child on a gluten-free, carbohydrate limited type of diet as well. So staying away from complex sugars. And that's pretty much it for that. Okay, we'll keep going. This is bipolar disorder covered in chapter 13. Bipolar disorder is characterized by periods of significant depression and periods of mania. A manic episode is a period of abnormally and persistently elevated, expansive, or irritable mood. During the period of mood disturbance, at least 3 of the following symptoms have persisted. 4 if the mood is only irritable and have been persistent to a significant degree. And these include inflated self-esteem, decreased need for sleep, more talkative than usual or pressure to keep talking, flight of ideas or subjective experience that thoughts are racing. So racing thoughts. You also have to have an increase of energy. That needs to be one of the hallmarks of the disorder. So that has to be one of the symptoms that have persisted. Okay. Distractibility, increase in goal-directed activity or psychomotor agitation, as well as excessive involvement in pleasurable activities that have high potential for painful consequences, like buying sprees, sexual indiscretions, foolish business investments. And this happens usually when the patient is having a manic episode. Mood disturbances sufficiently are severe enough to cause marked impairment in occupational functioning, usual social activities as it relates to relating to other people. At no time during the disturbance have there been delusions or hallucinations for as long as 2 weeks in the absence of prominent mood symptoms. So this is not a hallucination or delusional type of disorder. However, because a lack of sleep is one of the characteristics that you may see, the patient can have a reaction to their lack of sleep. So once they kind of hit that wall where they have to sleep, they may become delusional because they've been sleep deprived, but it's not a delusion or hallucination as a result of during that particular period of time that they're having a manic episode. It's not superimposed on schizophrenia or delusional disorder or other psychotic disorder. It's usually because there's physiological effects of a substance or a general medical disorder that it cannot be due to. So if a person is having a manic episode, it cannot be as a result of ingestion of illicit substance. Presentation of bipolar disorder will present with a manic episode, depression, and a mix of the both of them. There are 2 types of bipolar disorder. Type 1 is manic mixed episode, including a major depressive episode, and type 2, which is a hypomanic episode and major depressive disorder. Now, hypomanic just basically means that it's not to the same degree as a full manic episode. A lot of times people can have actually bipolar 2 disorder and function at work and so forth, where they have some characteristics of a manic episode, but not nearly as acute, not nearly as extreme. So they can be much more functional. These are the prevalence components of it. Age of onset is usually late adolescence or early adulthood. Sometimes it can happen after age 50, but late onset is more common in type 2. So the patient may have been living with it for a really long time and not really recognized it or had a hypomanic episode until they're later after the age of 50. We look at neurological secondary causes of mania, like non-dominant frontal CVA, non-dominant frontal tumors, Huntington's disease, and multiple sclerosis, not to be confused with actual bipolar disorder. These are neurological issues that can occur that can have very similar manifestations that look like a manic episode, but it's not categorized as bipolar 2 because there's an actual physiological reason. we talked about treatment earlier. Your go-to medication for mood disorder is lithium, but there are other anti-seizure medications that are also used, like carbamazepine, valproic acid, and sometimes we do use lamotrigine as well. Episodes can last, an acute episode can last anywhere from 5 weeks to 9 weeks with depression, and mixed can be up to 14 weeks. Now, obviously, you can't live in a manic episode for that long. So manic episodes are going to be much more brief versus depressed episodes. Let's see, we're going to talk, we're not really talking about cyclothymic disorder. It's just a variation of bipolar disorder. But most cyclothymic disorders now are just characterized as a form of BPD as well. Know that I wanted to see if there's anything else I need to. Oh, yeah, obviously you want to be aware that the neurotransmitter involved with bipolar disorder is going to be serotonin, dysregulation of serotonin. Okay, all right. Okay, let's go on to chapter 14, major depressive disorder. Some components associated with major depressive disorder is that depression can occur throughout a lifetime. It can be as a result of a significant life-altering event, but to truly be diagnosed with MDD or major depressive disorder, this mood has to last for a minimum of 2 weeks. So you have to see the disorder occur for 2 weeks or longer, with symptoms that include anything from anhedonia, right, to express that to you, and I don't care, fatigue, sleep deprivation, changes in appetite, either eating too much or too little, feelings of hopelessness or worthlessness, persistent thoughts of death or suicide, and inability to concentrate or make decisions, as well as changes in physical activity. Some of the depressive disorders that are classified as subtypes of MDD would be like disrupted mood dysregulation disorder, dysthymic disorder, that's just kind of always being sad or blue, premenstrual dysphoric disorder having to do with hormonal changes that can occur as a result of the female menstrual cycle, substance abuse depressive disorder that's either as a result of being on an illicit substance for a significant time or being off a significant time from the substance and then craving it and then being depressed as a result of not having it. And then depressive disorder associated with another medical condition, particular neurobiological disorders like CVAs or Parkinson's or MS, those types of neurological disorders. It's a leading cause of disability in the US. Don't forget that. It's the number one reason why people go on disability in stress, anxiety, and depression, the SAD triad. There are genetic factors that have actually been able to identify a gene. It's called HTTPI1, I want to say. Anyway, you don't need to know that, but it's kind of interesting. They have been able to identify an actual genetic gene that is passed down. So there is a genetic predisposition. Biochemical stressful life events can bring on depression. Again, it has to last 2 weeks or longer for it to be considered a depressive episode if it's as a result of a stressful life event, that as well. Alterations in hormonal regulation, inflammation as always, and that's the stress model, which is the nature nurture concept. Psychological factors, cognitive theory is, there's a degree of changes in the cognition of what's occurring, and it has a direct effect on the patient's ability to perceive life events from a perspective that they feel that life is hopeless and helpless. Learned helplessness is being unable to get out of that phase of feeling sad or depressed, and you've learned how to cope with it by this process of helplessness in as far as being able to actually address what the underlying issue is. All sorts of assessment tools, you'll see things like the HADS or the DAS or the what do they use a lot? I use the HADS a lot. PHQ-9. There's all sorts of tools used out there for assessment, depending on what unit you're in. Sometimes, like in the emergency department, they'll use hospital and depression scale, hospital anxiety depression scale, the HADS, in emergency rooms. Areas to assess our affect, thought processes, mood, feelings, physical behavior, communication, and religious beliefs and spirituality. Age consideration: children and adults can both have depression, and it can be significant in older adults as they deal with loss and changes in their ability to function independently. Some of the things you want to be conscientious of is that you have to ask the questions. You do have to ask if a patient has considered hurting themselves or hurting others, because of the fact that if you don't ask the question, you're not going to get the answer. And if there are reasons to intervene, it is our nursing responsibility to ensure that we've asked the questions and that we've elicited a response and how to address it appropriately. Okay. The phases, acute phase of treatment is like a 6 to 12 week period, continuation phase 4 to 9 months, then maintenance phase 1 year or more. Very important to be conscientious of the fact that this should be addressed through a dual modality, through both therapeutic means and medication means, in order to achieve the best outcome for the patient. So we know about if the patient uses a dual modality of medications and therapeutic treatment, their chances of successfully being treated for depressive disorder is about 85%. SSRIs are your first line therapy. We need to know what the indications are, if there's any potentiality for adverse reactions, and talk to patients about potential toxic side effects, such as serotonin syndrome, where there's an overabundance of serotonin. It's not breaking down fast enough, and the patient can have a reaction to the medication. Most often it's going to manifest like in a rash, and it is definitely important to intervene quickly if the patient has serotonin syndrome. I'm not going to go over the psychopharmacology because we kind of went over that at the beginning. Okay. We're going to look at anxiety and OCD related disorders. Anxiety is normal. It really stems from apprehension, uneasiness, uncertainty, or dread from a real or perceived threat. Now, the reason it's normal is because a real or perceived threat can potentially also be real in nature, can have a substantiation behind it. However, if the anxiety becomes so pervasive and it's not responding to appropriately to the situation, where it becomes so all-intensive or so pervasive that it's difficult to function, that's when anxiety no longer is classified as a normative response, because you're not reacting to it appropriately. Fear is a reaction to specific danger, and normal anxiety is necessary for survival because it taps into that fight or flight response to ensure that our safety is there. But again, anxiety that's not normal in relation, where you're unable to function, you're so apprehensive and so scared and so uneasy, and you dread things that are really not as acute or concerning as you're perceiving, then it's going to affect your ability to function, which again was what we're trying to achieve. Anxiety is classified into 4 separate sections: mild, moderate, severe, and panic. Treatment wise, really, all the medications can be used for anxiety as well. In order to address anxiety, the go-to is always therapeutic. So we want to actually start the patient on therapeutic means before we start them on medications, get them incorporated into seeing a therapist, and then start treating them with medications. But what happens is if you start treating therapeutically secondary to medication management, patients can potentially misuse their medications, like anxiety medications for severe anxiety or panic attacks, like your benzos. And really, we want to get to the root of what's causing the anxiety, and that's best achieved through talk therapy. So make sure the patient is incorporated in therapeutic means. Some of the things, there are different types of separation anxiety disorders: developmentally inappropriate level of concern or being away from a significant other. When you're a kid, it's okay to have separation anxiety disorder, particularly if you're a little one, baby, 2 or 3 years old. But if you're still doing it at 18 or 19 years old with a family member or your wife or husband or significant other, then there's cause for concern. Panic disorder or panic attacks will have a physical manifestation associated. So racing heart, sweating, pallor. Patient may have tachypnea as well. It often mimics looking like a cardiac event. Agoraphobia is excessive fear about places or situations from which a person can't escape. These are often what we call the shut-in. Person doesn't leave their home because they're uncomfortable going anywhere that's foreign to them. Social anxiety disorders, severe anxiety or fear provoked by exposure to a social or performance situation. And GAD, which is what most patients with anxiety are classified as, has to occur for for a significant amount of time, like meaning that it lasts months. So, it's important to identify what kind of anxiety they have, but most people fall under general anxiety disorder from a treatment perspective. And it's just got to last, a significant amount of months. There's not a particular number associated. These are some other issues why a patient might have anxiety, like substance-induced anxiety disorder and anxiety due to medical condition. When we look at obsessive compulsive disorders, we're looking at thoughts, impulses, or images that persist and recur so that it cannot be dismissed from the mind. And compulsions, this is where you've got ritualistic behaviors. An individual who's driven to perform an attempt to reduce anxiety. It's like turning the doorknob 10 times, checking the door 10 times before you leave, not stepping up cracks on the floor, just like these ritualistic kind of odd and peculiar behaviors, but they help to lessen the amount of anxiety because there's some sense of control. These are other OCD-related diagnoses. Body dysmorphic disorder is often characterized by patients that have pervasive plastic surgery or cosmetic surgeries where they're always wanting more regarding how they actually see their bodies. So they will continue to do plastic surgery till they find that ideal body type. But the problem is they're constantly chasing what that body type looks like. So they're never really satisfied. Hoarding disorders, hair pulling, tryptophilia, and skin picking disorders are also manifestations of compulsive disorders. Okay, anything? Counseling important, don't forget that. Antidepressants, anxiolytics, and other classifications of medications. There's different types of behavioral therapies that we can use, like cognitive behavioral therapy, which is very successful in PTSD, behavioral therapy, like relaxation training, modeling, systematic desensitization, CBT, and so forth. Okay, we're going to start with EDOs. Let's take a look at these last two areas. Okay, we're going to look at anorexia and bulimia specifically. Anorexia is characterized by a refusal to maintain a minimally normal body weight. However, bulimia is characterized by repeated episodes of binge eating followed by inappropriate compensatory behaviors like self-induced vomiting, misuse of laxatives, diuretics, fasting, or excessive exercise. This also has to do with the disturbance in the perception of the body shape and weight, and it's an essential feature of both anorexia and bulimia. With anorexia, again, refusal to maintain body weight at or above a minimally normal weight for age and height. So it's height versus weight. The weight loss leads to maintenance of body weight less than 85% of that expected, or failure to make expected weight gain during a period of growth, leading to body weight less than 85%, again, of that which is expected. It's characterized by an intense fear of gaining weight or becoming fat, And even though the patient is underweight, it's disturbance in the way one's body weight and shape are experienced, denial of the seriousness of the low body weight. In postmenarchal females, amenorrhea can occur in the absence of at least 3 cycles, menstrual cycles. So we see this a lot with athletes as well. Those who have to maintain a specific body structure, like gymnasts or ice skaters. You're going to often see depressed mood, social withdrawal, irritability, insomnia, and diminished interest in sex. You can meet the symptomatic requirements for major depressive disorder, which is secondary, but it's almost always a co-diagnosis associated with anorexia. And it can also be a manifestation associated with things that are, the physical sensation of starving as well. Let's see, some of the symptoms you're going to also see things like constipation, abdominal pain, intolerance to cold, lack of fatty tissue, lethargy, excess energy. So they get like these spurts of excess energy, and then emaciation, just being severely underweight. And then bulimia, on the other hand, is characterized by recurrent episodes of binge eating. An episode of binge eating is characterized both by eating in a discrete period of time, usually within any kind of 2-hour period. And then you just eat these mass amounts of food. And then the sense of lack of control over eating during this episode, that it makes them feel like they can't stop eating or control how much. And then their compensatory behavior is to then vomit or take laxatives. Sometimes they'll do enemas as well, diuretics, and other types of medications, fasting or excess exercise. Binge eating compensatory behaviors both occur on an average at least twice a week for about 3 months. So there's criteria associated with how often the occurrences happen. Self-evaluation is unduly influenced by shape and weight. However, most people with bulimia just, they don't show signs of being underweight. In fact, most of the time they look at normal body weight and sometimes a little bit above body weight. Typically within the normal weight range, some maybe, like I said, slightly overweight. Between binges, individuals typically restrict their total calories consumption and avoid foods they perceive to be fattening. While binge eating, food types tend to be high in carbohydrates and like cakes, ice creams, sugars, things like that. There is purging and non-purging type too. So non-purging would be like the excess exercise. Okay. All right. Okay, guys, I think that's pretty much it for sharing with you guys. There's a couple other things on the study guide I need you guys to go over as well, but those are going to be most of the topics we're going to be covering for the final. There are 50 questions and 6 bonus questions on that. So the final won't be graded until or won't completely be graded until after you've completed the test. Okay, I hope this helps a little bit. Good luck. Talk to you later. See you in a couple days. Bye.